Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you this morning on this beautiful Tuesday morning, so early in January. We're broadcasting live from the Dolph Simons Family Studio. I'm with my right-hand guy here, Doc Hawk. Always happy to be back with you today. We're joined here in the studio by Mario Castro, the Vice Chair for Clinical and Translational Research here at KU, who's going to be sharing news of 2 new outpatient therapy trials around COVID-19. We're also joined by our good friend and colleague and KDHE Secretary Dr. Lee Norman, who's going to help update us about the vaccination status in Kansas. But first, Hawkeye, how are we doing this morning?
You know, quickly, I think we are, again, a little bit more pleased today and this past week, really. Our total number of patients is 115, but 64 of those are in that acute infection stage, 23 in the ICU, and 13 of those patients on the vent. So that proportion is still significant, but down a little bit. 51 in that what we call recovery period, but again, 115 total still needing to be hospitalized.
Not bad for us right now.
I think, you know, again, I think we're optimistic. Keep those numbers down as much as possible. Hays, you know, they have been at a plateau. They've inched up slightly. They did have a death overnight. 26 total with 21 active infections. So hopefully they won't inch up anymore. It can stay low as well.
And we've talked a little bit, we had a lot of COVID deaths in December, by far our highest month.
Yep.
And so we know that the disease is still highly active, still very bad, and we're a little nervous about the numbers that are here. Our rolling 7-day average in Kansas City is over 1,000 again, and then unfortunately that takes about 2 weeks for us to start getting hit by that, and so I'm a little nervous about what the future holds, but I'm hoping that vaccination in nursing homes and things like that are starting to have an effect.
And I think hopefully that will be true. Again, even though we're happy with our acute numbers, we have to remind the public that those, just because the numbers are the same, they don't indicate the number of deaths. And to your point, December was a horrible month for deaths.
Very difficult. So, well, Dr. Norman, we are so happy to have you back here. I think you're going to be with us a series of Tuesdays, which is great. And we'll have some fun messing with you, and we'll have some fun learning from you. So I got a couple of questions before we let the reporters get started. First of all, over the weekend, you tweeted that Kansas is now in the top tier of states providing vaccination on a per capita basis. Some places have us reported as 50 out of 50. Help us get to you're saying we're in the top tier. And by the way, I think we are too, but it's hard to prove that with some of the data.
No, it's not hard to prove it, actually, Steve. We were never 50th out of 50. It was we pushed out vaccine as soon as we got it, and it went into people's arms almost as soon as they got it. 278 testing sites. What the problem was what the CDC data that they were pulling from our WebIZ, which is the reporting system where all the vaccinators need to put the patient information in, and then it gets uploaded to the CDC. So that was where the glitch was. When we worked with the CDC to get the data flowing well, and there's some of the sites that do the vaccines that have never used WebIZ, and as you know, sometimes with the new IT application, it takes a little while to become facile at it. So the summary is 190,000 doses have gone out to the state of Kansas. From the very first weekend that we got the vaccine, it was in every single one of 105 counties, and the data's catching up. We blew by 30 states just since last Friday to be in the top tier. The top tier will be a moving target because as more vaccine comes in, the bar will get higher and higher, but we're working at it.
Yeah, I think that was where I was headed too, is at the exact same point that the problem wasn't that we weren't getting the vaccine in. The problem was that wasn't really being registered, and so as a result, it was hard to prove. Now we can prove it because we got the data around it, but we've known it for a long time because we've seen as soon as the vaccine came in, we were giving it to people. I think that was the key part. So this morning, the CDC has announced that they're going to change and shift gears a little bit and saying everybody over the age of 65 should be considered Tier 1A, and we should push all the vaccine doses out, similar to what we've heard President-elect Biden talk about. How's that going to affect Kansas? How's that going to affect our vaccine efforts?
It won't change really anything for us. I'll show you a slide in a minute that has our phases. We decided, and working with the governor and our communication staff, to not do the 1A, 1B, 1C, because every state was doing that, the labeling different, and it was very confusing for people. So we have very cleverly have 5 phases of vaccine administration, and we call them 1, 2, 3, 4, and 5. So we are in, there we go. We are right now in the first phase, which is healthcare workers, long-term care, and then some critical infrastructure people that need for continuity of government and continuity of operations. we hope to be done with this phase by end of the month. And then, as you can see from phase 2, we already had made that decision before the CDC came up with it to have it be the break point in terms of age, 65 plus, congregate settings, and then high contact, what we call critical workers. And this graphic, by the way, comes right off of our new Kansas vaccine website. And I would recommend people bookmark this. It's www, very cleverly named, kansasvaccine, one word, .gov.
Well, you spent some time on that one, brother.
Yeah, I know. It's didn't have to fight anybody for the nomenclature, and it has a lot of background material. And I'm going to show not yet, but I'm going to show you some more information here in a minute. As to why we came up with this, and one of the things that I think is really important to know is that we didn't pull these prioritizations just out of thin air. We worked with the ACIP, the Advisory Committee on Immunization Practices. We're blessed to have Dr. Kevin Alt at KU is on that committee, and additionally the CDC and the Department of Homeland Security has something to add to this in terms of who's critical and workers and essential workers. And then finally, and really quite importantly, we have our own standing COVID-19 Advisory Council. And it represents different kinds of populations of people of color, different business sectors. It includes medical and bioethics. And they help shape this in a very important way because we wanted to make sure that it was fair, equitable, and yet based in science and something other than just a popularity contest. So I think it's, and when you go through it's about 8 or 10 slides that you'll see on that website. I think you'll find it to be very explanatory. It says what is each of these phases and defines them quite clearly.
Well, I think that is really helpful. And what do you think is going to be the best way for folks to learn how and where to get the vaccine, Dr. Norman? Because I'm already getting questions from my patients. How will I know? And I'm over 65. I want to get vaccinated. Heck, one of my 31-year-old CF patients got a call from a transplant center in Dallas, Texas, inviting her down and come down and get a vaccine tomorrow. And it's just so crazy. So how are people going to know when and how they get it?
The website that I just gave you will have the information about phases. And I will say that, we have 105 counties, and every county isn't going to act the same as every other county. We've already have counties, for example, that have gone all the way through phase 1, and all their healthcare workers and long-term care facility persons and staff are vaccinated. And so we've taken the approach that if there's extra vaccine that can be shared with nearby counties or communities that still have healthcare workers and long-term care persons that haven't been, then share the vaccine, and we give them the authority to move it over as such. We don't want vaccine on shelves, and we don't want vaccine to be wasted. And we would move into 65 plus now if it were in a county, for example, that they've already given their phase 1 people. The surrounding areas don't need additional vaccine, and go ahead and move ahead into the next phase.
There you go. So let's see if there are questions out there from reporters for Dr. Norman or anyone on our panel.
Sure. Good morning. Cody Holyoke, KMBC 9
Cody.
News.
Good morning.
Hey. Thanks, sir. Dr. Norman, I know last month, well, first off, we'll set up by saying Trump administration is asking states not to hold back on second doses to speed up vaccinations. And I know last month I asked you that question. Does 150,000 doses mean 150,000 first doses? And you said yes. So was Kansas even doing that? Were they holding back doses for a second round?
No, we've never held back doses for a second vaccine because the second dose, we are giving second doses, but it's because a new shipment has come in specifically of second doses. For example, this week we've got 17,000 Moderna vaccines coming in. That will be first doses as we move through the phases, and 5,000 doses of Pfizer vaccine, and all those 5,000 will be second doses from people who got the Pfizer vaccine 3 weeks ago. So that's what our total allocation is, by the way, 17,000 plus 5,000. That it's important, that doesn't include what's going to most of the nursing facilities and assisted living, because those come in through what's called the federal pharmacy partnership with Walgreens and CVS, and they are doing the vaccinations themselves to those federal through the federal pharmacy program. So our limiting factor is the amount of vaccine we get. We've got, like I said, 276 vaccinating sites. We have a capacity to double that and to go to mass vaccination sites. But why set up a mass vaccination site when you don't have any vaccine?
Right,
Yeah,
makes sense.
It's interesting. We had a call with Wyandotte, Johnson County yesterday, and trying to make sure we were coordinating and helping distribute vaccine and move it around a little bit. And hats off to everybody working so darn hard at it. But I think Wyandotte, Johnson are ready to go with mass vaccination clinics. We've had a mass vaccination clinic here at KU. We did 2,000 patients, or nearly 2,000 in a single day. We're all ready to go. It's just like you said, we're all dressed up with no place to go because we don't have the the vaccine.
Yeah.
And so once we get that, I think we'll be in good shape for getting into arms, which really solidifies the earlier point you made, Lee, that it's not like the vaccine is coming to Kansas and sitting around. It actually is going into arms, and we just need more of it.
Right, and the data will continue to lag. The reason is a lot of these vaccinating sites in hospitals are actually a good example. Many of them are not traditionally places where people get vaccinated. And so when you go to, and by the way, there's a really good website by the CDC. It's put in COVID-19 vaccine data tracker. And you can see how many doses are going into people state by state. So that's why we're in the dark blue, which is the top tier. And I hope we get enough vaccine to really, that's our fair share, quite honestly. You know, we have 3 million people. That's slightly less than 1% of the population. If we get on a per capita basis amount of vaccine, then we're going to get it in people's arms. But the data may lag, so people just have to understand that we would rather have people putting vaccine into people's arms than necessarily saying, no, wait over there, ma'am, I'm going to put in the data from the first one. I'll get to you in a minute. We like to run people through, gather their information, then batch enter it. So the data will always lag.
Are some states getting per capita more vaccine than other states?
Not according to operational warp speed and the Trump administration.
Other reporter questions?
Just a quick follow-up. Dr. Norman, you mentioned 190,000 doses out to the state of Kansas so far. Do we know, and obviously you're talking about a lag in reporting, do we know how many shots have gone into arms?
Well, pretty much all of them have been injected already. What the WebIZ shows is the data entry has us at 84,555, and that's a big gap between 190,000. But those other ones are going to be entered in. And by the way, every state's having the same data issue. So when you get in at the data tracker, you'll see that there's and just hover the pointer over any state, and you'll see there's that same big delta. And the reason is people are all coming to the same conclusion, which is the vaccine does more good in people. But that data lag should be steady as time goes on, because we're still going to be having this conversation in, April, May, June, July. I mean, at 17,000 plus 5,000 doses, you can do the math and figure out it's going to take a long time to march through these phases. Phase 2 is the biggest number of people, and we're going to be stuck in phase 2, vaccinating people for probably at least a couple months.
Just to say what we've learned is if it takes us 15 minutes to do a vaccine from start to finish, including the observation period, it takes a little longer than that to do the data entry period. And so that was a real struggle that you had. And fortunately with the EMR, now that we've converted ours to Epic, so actually the download's very swift. So it's gone a lot faster. But man, it took a while when you didn't have that automation. Other questions?
Hi, good morning. Jordan Betts from Channel 41. How are you guys?
Good morning. Good morning.
Morning.
So I have a question. As more and more people get vaccinated, do you guys worry about people being COVID shamed about getting the vaccine? And kind of what I mean by that is someone that's, I would say, not in super direct contact with COVID patients at the hospital getting the vaccine. Maybe they posted online, and then they're kind of getting shamed by people saying, oh, you're not in super direct contact. What do you tell people if they're getting that kind of shame? Because I'd say it down the line as even the public gets that. Do you worry that could happen?
Lee, my response is, let's just get the vaccine. What do you think?
Yeah, I think that I wish people would think of their fellow man, and if they reconcile the fact that they're at lower risk and somebody else should be getting it, I think that people should be honest. Having said that, I agree with Dr. Stites. I don't think there's any purpose. There's no benefit in shaming. That's not how behaviors are controlled. We have 296 policemen posted at 296 vaccination sites? No, we're obviously never going to do that. And I have to admit, phase 1 is easy because people know who their employees are. people know who's a resident of a nursing facility, for example. People know who their nursing facility staff is. But it's going to get a little squishier when you get into subsequent phases, and we rely on people, I think, subrogating their own personal desires for the greater good. We'll see if people do that, but I don't think shaming gets us anywhere.
It gets us nowhere, and I think the problem is you never know the relative story, right? Somebody could work for a hospital somewhere, and they decide, well, I'm going to vaccinate my IT department because if my IT goes down, my hospital closes, and I can't take care of COVID-19 patients, and that's a real stress point. Okay, I'm going to have a hard time arguing that point. On the other hand, I got another place to say, well, I got to protect all the police force, I got to protect all the firemen. These are all good and valid stories. Our challenge isn't that one person's story is better than another. Our challenge is we need more vaccine, to your earlier point. Yeah. And that's why I say the key is let's get the vaccine in. Please.
Hey, can we see that second slide? Because it touches on what Steve just talked about. I think it'll be important. This is the federal, the KDHE guidelines that we pulled in from those various sources. And I realize the footnotes are kind of small, but it's CDC and others. And to Steve's point, if you look here, in addition to health risks associated with clinical outcomes and death, obviously older people have, if they catch the disease, and Dr. Castro sitting there and Dana and Steve will tell you that they don't do as well. So clinical outcomes and likelihood of death are part of it. Proximity, residents and staff are less than 6 feet away. In other words, if they are stuck and they can't distance themselves. Type of contact where there's more likely to be droplets and shared surfaces, common items, and that could be in food production, for example. The average interactions last more than 10 minutes. In other words, people are in a setting where they're not just two ships passing in the night, but they're in close approximation. And then spaces indoors compared to outdoors, et cetera. So these are the filters that we put our recommendations through and where we came up with 1 through 5 with a little bit of fine tuning.
All right. Other questions?
I have a follow-up question to that.
Please.
Are you guys vaccinating volunteers yet? I know some hospitals are doing it, and it says in the first phase, non-paid workers are in that. If you guys are vaccinating volunteers, will you guys tell me why that's important that you are vaccinating these volunteers?
Yeah, I can tell you we are not vaccinating volunteers at this time. We are considering it, though, because we have some patients, some volunteers who may help us in a mass COVID immunization clinic. And if that's the case, then they're essentially a frontline healthcare worker. They're going to be exposed to 2,000 people a day, and at that point, we will vaccinate them. But in the interim, we are not planning to do that, and we have not vaccinated volunteers. Other questions?
This is Ellen McNamara with KCTV5. Good morning.
Good morning, Ellen.
Good morning.
Yeah, sorry, you might hear my dog bark, so I apologize for that.
That's okay. It just feels real.
Yeah. Dr. Norman, first off, with the data, is there a separate data entrance system for the state and the federal government? So you have to also enter it into, 2 separate places. And then my other question is, what is one thing you would recommend that the Trump administration do differently? Just one thing that you would say, this would make things easier. I'm assuming we need more vaccine, but is there one other thing that you would also recommend?
Yeah, those are both really good questions, Ellen. Number one, WebIZ is the system that puts in the patient information. And you can think of it as a medical record because it contains personal health information. And that's what the provider puts the patient identifiers in. All the vaccinator sites also have one federal system that's called Vaccine Finder. And all it is an inventory system. And we've used that forever. This is not new. In other words, if sites had somebody go into, Egypt or something, and they needed yellow fever vaccine, they could go into Vaccine Finder and find it where it is. So it's used for many different kinds of vaccine inventory. So yeah, they have to put, the WebIZ takes a little bit of time unless there's that interface like Steve talked about with the electronic medical record. And then the Vaccine Finder for inventory purposes only doesn't contain patient information. And by the way, our data use agreement with the CDC does not, we did not choose to send personal identifying information to the CDC. We feel that Kansans have let us know that they would prefer that their patient information stay home, in the state of Kansas in a protected system.
Other questions?
Charlie Keegan here, 41 Action News. Has a lot of questions for you guys this morning.
Hey, Charlie.
Yeah.
Guys, I've heard from folks in Wyandotte and Johnson County about people who were vaccinated ended up getting getting COVID after getting the vaccination. I'm not saying they got it from the vaccine. We know that's not the fact, but they may have been exposed the day before they got their vaccine or something. What do you have to say as a reaction to hearing about that?
Yeah, first of all, we know, Hawkeye, that it takes 6 weeks before you're protected. So nobody's been vaccinated for 6 weeks so far, so therefore it's not that wouldn't be a surprise. Second of all, what you've just recited is a very small number of people. It's not the majority at all. Third, I would expect that those numbers will diminish as we get more people vaccinated, Hawk.
Yeah, to your first point, this vaccine, Moderna and Pfizer, will not give you COVID-19. So that's a very good point. Second of all, we know that happens. That was looked at in the studies, looking at infection in the people who got the vaccine and the people who got the placebo at 7 days and 14 days. We see that they are similar until that 14-day mark, and then those curves really start to separate, and the people that got only placebo got infected more often or had disease more often than did those people. So to say that I got COVID-19 after getting the vaccination, that is not unheard of. That is very well documented in those studies, and I don't know if Dr. Castro has anything to add.
Yeah, no, I agree. In fact, we test people. We do a swab at the entry when we give them the vaccine in the study, because this is the exact thing that happens. They tell us 3 days later, hey, I'm starting to get COVID symptoms, and then we run that swab. But I think the real message is, after you get your shot, you got to do the mask, you have to do the social distancing, you got to do all those things that you just can't give those things up.
Yeah, rules of infection control do not go away because you've been vaccinated. Exactly. And remember, they're not going to go away even after we have a whole bunch of people vaccinated until we know COVID-19 has gone away. Then we can start thinking about taking the masks off and going back to life as normal. Lee, anything you want to add to that?
No, I think that pretty well covers it. I do want to point something out, that Dr. Mario Castro sitting there with you, has been he and Satterwhite, Dr. Lewis Satterwhite, put together a group of critical care physicians that meets every other week. I sit in on that. My counterpart, Randall Williams, MD, on the Missouri side, sits in with that, and it has been a terrifically informative group to help us think and help us to shape policy from people that are right on the front lines. Because I do not want to live in an echo chamber where we make public policy based on something that just comes out of Washington, D.C., for example. And so thank you, Mario, for doing that. Similarly, Stites and people in Wichita, throughout the state, I have 2 hospital groups, that larger hospitals and smaller groups, and the smaller group hospitals will meet with me today by phone in the afternoon, like we do every other week. Again, I want to stay very close to the front lines with the informing us, so that the things that we do make sense. And I'd like to make sure to acknowledge all of our hospitals and Mario and Lewis and that group for helping so much during this time of steep learning curve. Been immensely helpful.
Yeah, he's done a great job, but we're not going to be any nicer to him now. We're done. All right, other questions? Reporters.
Dr. Norman, this is Ellen McNamara with just one quick follow-up question. Obviously in the metro, there are so many more frontline workers. There's more healthcare workers in the metro rather than, in western Kansas, for example. We spoke to a doctor in Johnson County who's not affiliated with a hospital group, and they were just wondering, when can they get the vaccine? How do they know when they can get the vaccine? And they're in Johnson County. Thanks.
Yeah, they can get it now. They've always been able to get it. The healthcare worker in phase 1, it doesn't make any difference where they work, whether they are in phase 1, they're in phase 1. They can go to they can contact their local health department, the safety net clinics. Some hospitals are reaching out even to non-affiliated physicians. That's happening at Stormont Vale and Topeka, for example. But the health departments are allocated vaccine, and as are the safety net clinics, and eventually we'll have medical groups themselves and pharmacies in the community vaccinating as well. But they can go get that now. They just have to make an appointment with the health department.
And Lee, is it your sense that the number of vaccines that have been given to each county is done on a pro rata basis? How does the state determine how much vaccine to give to, say, Ellis County, Sedgwick County, Johnson County, Wyandotte, et cetera?
Yeah, it's essentially on a census tract per capita basis.
Okay.
Yeah.
All right, other questions?
Lee, I have a quick question for you. One of the things as I've been out there in the community is vaccine hesitancy, and what can we do at a statewide level and a public health level to address that? Because unfortunately, the most susceptible to COVID and with the highest morbidity and mortality are some of the highest hesitancy groups.
Right. I think that, why do people get vaccines? And they basically do it for a couple of reasons. One is out of fear. They're afraid to get the disease. The second is because somebody tells them it's a good idea. And I think one of the things that we have to do is make sure that our medical providers, nurses, et cetera, are unabashedly enthusiastic about giving the vaccine. Those are the two things that turn people's behavior more than anything. The third one is marketing. And for example, the CARES Act money that has provided millions of dollars to the state, we haven't even seen that yet. It's we have money coming in on the 19th or 16th of this month. That is some of the CARES Act money that, remember, the president, I think on the 28th of December or something, signed the bill finally. And so it's like water trickling out of a hose. It's finally getting to us. We're going to put together, are in the process of putting together a pretty aggressive marketing campaign. Hopefully that will also give people a degree of comfort. I think the other thing is that we got to keep talking about this and how successful this vaccine is in the sense of, one, how that it works, and then secondly, the paucity of side effects and complications. We follow those complications and side effects pretty closely, and it's been very well received. Yeah, people get an achy arm and maybe a headache or a bellyache or something, but for the most part, it's been very well received and with very little side effects. So those are the three things that come to the top of mind, Mario.
Thank you.
And just to say, we've been able to vaccinate thousands and thousands of people here at KU, and so that's been a great thing. Side effect profile, Hawkeye, very, very low, much better than it is with Shingrix or even other vaccines. So very safe. You and I think we've all three had the vaccine.
Yes.
No, it's fine, and I'm ready to go with my second dose. And had a little bit of arm soreness. I had to call Pat Mahomes and tell him I couldn't pitch the ball with him right there, throw the ball as well. But other than that, it's been all good. I've been all good. All right. Any other questions from reporters? I want to thank Lee Norman. I know you're going to have to jump off in just a minute. It's about 8:30, so thank you very much. I also want to bring back turn to Dr. Castro now. He's done a great job, but we're not going to say anything more nice about that. That's painful. But we are going to talk about some of the new news about research here that he's been so closely involved in. Mario, we've talked in the past about the FDA, EUA around monoclonal antibody therapies. Let's talk a little bit about what those are and what these new research trials you are going to launch have and how that compares, because we already have a couple of products out there. Why are we doing a couple of new trials?
Well, we currently have 2 monoclonal antibodies available for treatment of mild to moderate COVID. We know that it has to be treated in the outpatient setting. It has to be when it's in early phases. Once we use those in the inpatient side, it's not as effective. The disease has really advanced too far. What's exciting is that we're going to be studying here at KU 5 new agents for this. And so there's really a lot of emphasis. We as physicians know that one treatment, one bullet is not going to treat all disease that we have because there's so many different manifestations. So we really need to expand that treatment. If you can think about what Hawkeye does on the inpatient side versus outpatient, you use oral antibiotics, you use IV antibiotics, you need to have a number of different choices. So we're now enrolling for a new infusion called BRII, B-R-I-I. This is 2 different monoclonal antibodies that have been put together as a cocktail, and they block the binding of that coronavirus to the receptor, the ACE2 receptor. Because it's a cocktail, it's a mixture, our hope is that it will have less problems with viruses mutating and causing resistance. The other thing is that one of the antibodies that have been developed has a formulation that a change in the amino acid structure that allows it to last longer, has a longer half-life because of that. So we think that this might be a very good advance over what we currently have in the 2 monoclonal antibodies that are available.
Sounds good. So help me understand. One thing I know that can be a little confusing to folks is that we've talked, there's some data that came out last Friday, I think, that talked about high-dose convalescent plasma working early in hospitalizations. I think it was from England, had really reduced some hospitalization. Why does that work in the inpatient side, but the monoclonal antibodies that are biologics, they don't work on the inpatient side? Is it a timing issue? Help me understand that difference a little bit.
Sure, and I'll ask Hawkeye to chime in
you
here as well.
Because I really don't know the answer, so that's why I'm asking you to.
I think it's unclear exactly why the convalescent plasma worked in that situation. Relatively small trial, and there have been other ones that have been negative as well. So I do think that when you think about monoclonal antibodies, it is a purified antibody. It's a one approach to the virus itself. Perhaps the convalescent plasma gives you multiple antibodies, multiple ways to combat that infection. It might be more effective in that regard. But in general, most of the data I've seen has not really shown that convalescent plasma has been that home run that we need on the inpatient side at this point.
Hawk?
Yeah, it was a small trial. I think we need to say that. I think the important thing there is that they got it infused into those patients within, I think, 72 hours of symptom onset. So you are still in that early to mid part of that acute viral infection, that viral stage prior to getting to that inflammatory or immune dysregulation stage, and earlier is definitely better. I think that's what helped. But again, it was a very small trial. Unclear whether there were other confounders there as well. So I think we just put that in with the other bulk of our information. Earlier is always better for these monoclonal antibodies. And if we get an oral antiviral treatment that we can take, just as we do, say, Augmentin or a Z-Pack or anything like that, if we can get that early antiviral treatment as an outpatient, as a pill or something, that will help as well. But I think the key part in that study was the rapidity, the soon after symptom onset that they were able to get it infused.
Yeah, I think hopefully we'll learn more over the coming weeks. As we always say, we're building the airplane while we fly, and we learn more as we go. Any other reported questions? Go ahead.
I do think shown up on the screen is the trial criterion. I just want to touch upon that briefly, Steve, if it's okay. So because this is an IV infusion, what we've done is we've taken a different approach with the IV infusions as we're enrolling participants that are in that elderly group that are the highest risk. So if you have mild COVID infection or moderate COVID infection, you got your positive test, call us and contact us if you're age 60 and over. Now, if you're under 60, but an adult, 18 and above, we require that you have some comorbidity. And so we've listed those: smoking, high blood pressure, being overweight, active cancer, chronic lung disease, kidney, liver failure, or being immunocompromised. And we'll screen you on the phone and let you know whether or not you qualify for that. Now, as we move on to thinking about the symptoms that are important for getting into the study, as Hawkeye mentioned, we're going to take everybody that is 10 days or less symptom-wise, but I prefer it 3 days or less because that's when it really works. So the sooner after that positive test you contact us, the better. And so you have to have a positive test. We need to know where that result was, where that test was performed. And then you have to have one of these other symptoms, just one. A low-grade fever, a cough, shortness of breath, maybe you're having some GI symptoms, runny nose, all those things would qualify. And what I'd like to stress is we need, you may blow it off. You may say, oh, this is pretty mild, but you don't know what's going to happen tomorrow or what you're going to wake up with tomorrow. So contact us, if you're having those early symptoms, let us get you into the trial. This is really an effective treatment based on the emergency use authorization monoclonal antibodies. But this new treatment we have to test, and we have to compare it in this trial in order to advance the field. Our contact there is Luigi at 588-4022. Please contact Luigi if you're interested in participating in the trial.
Yeah. Thank you. It's exciting to see these kind of trials out there. How does one say, well, I want to be in the trial versus I should just go get the monoclonal antibody, for example, if they're over 65?
Sure, and I think those are great options to have. One, certainly contact our health system, and you could potentially through our infusion center if you meet certain criteria. Now, those criteria are set, and maybe Hawkeye, you can touch upon
well,
those.
They're a little stricter than the others. So I think there's a group of patients here that aren't going to get the monoclonals that can be in the trial,
Yep.
which I think is
Yeah.
a great opportunity, especially for somebody like me. I'm 60, going on 61.
Yeah, I think the other question is access. We want to get more people infused with those monoclonal antibodies if they meet that criteria. So we've expanded it to the ER in some cases. We have our infusion center, but there are bottlenecks there. There are reasons that we aren't able to infuse as many people as possible. Staffing is always an issue. Getting that test and really getting them screened is important. We'd like to be able, for as many people who meet the criteria, to get it, to help hopefully prevent you from going to the hospital.
All right. Jill, let's see what questions are out there.
We do. We have one for Dr. Castro this morning from Carol, but it's not about this just yet. She wants to know if you've had any word on the AstraZeneca and an emergency use authorization. I don't even know if you can answer.
Sure. We've reached over 32,000 enrollees into the AstraZeneca trial. At this point, till the end of this week, we're still enrolling in the vaccine trial, but we're only enrolling those that are elderly, above age 65, and from a minority group. So if you qualify, we're still enrolling this week. We definitely believe that this is going to be another vaccine available for us. It has been approved outside of the U.S. already in the UK, in some other countries. We think that will likely be part of the picture that will be evaluated here in the U.S. By the FDA. But they need this phase 3 study that we're completing right now, the results of that, in order to make that decision. We won't have those results till March or so. So it's going to be, I think, likely in that time frame, early spring, that we're going to get the results to the FDA for review and approval of the AZ vaccine if it shows that it's safe and effective.
We sure hope that it is, because we need all the vaccines we can
Yep,
get. It would
exactly.
be great, because as I recall, one of the advantages of the AstraZeneca vaccine, and I think the Johnson & Johnson one, is that it doesn't require a lot of fancy refrigerator or fancy low temperatures. It's easy to produce, and it can be distributed throughout the world because it doesn't require all the super cold temperatures.
Yeah, I agree, Stephen. And it is something that we know in lower resource countries, you have to have this kind of an option in order to get it out there. And at the end of the day, we believe this will probably be the #1 vaccine used. As long as we show, again, that it's safe and effective, it will likely be the #1 used in the entire world because of that advantage in terms of administration.
Did they ever go back and look at the half-dose first shot and then the full-dose second shot, kind of what that little small group in England found?
Yes. Yeah, no, it's been looked at, and at this point, we're sticking with the full dose.
Okay.
Because those half dose has really not shown to be to an advantage. And also, people have also looked at just getting a single dose. And again, we know that's not sufficient.
Not as effective. Yep.
Yep.
Okay.
Judy wants to know, do the first and second doses contain the same formulas? Is there any potency differences? And we had another person that was asking about mixing.
Well, let's talk about different kinds of mixing.
Yeah.
So first, differences between the Moderna and the Pfizer vaccine. Really, it's the same vaccine both times.
It's the same vaccine. There are differences in the total amount, but that is not significant as far as causing immunity or immune reaction. Pfizer, I believe, is 30 micrograms per dose. Moderna is 100 micrograms per dose, and again, that is the amount of the RNA in those vaccines. So really, no difference. But otherwise, I think they're essentially the same.
And you really shouldn't mix the two different vaccine types from one to another.
Right. At this point, we're not recommending mixing that because we just don't have any data. What happens when you do that? And so the recommendation at this point is not to, stick with the program that you have. Get the Pfizer one or get the Moderna one, and then hopefully down the road, the AstraZeneca one.
And, I think the other thing, Moderna said in front of investors, I think it was yesterday, to a group of investors, that they think their vaccine will be effective for a year and may require annual boosters.
Great.
And that would be great.
Yeah.
We want to see that data.
Yeah,
exactly.
We are
It's
all
going to take a
hoping
while,
it
but that's
will.
what they're predicting.
Yep.
All right. Jill.
Yeah, so here's a question from Melissa. Are there any studies of those who have been reinfected with COVID?
Okay, what's the data around patients who are reinfected, Hawkeye? How are they doing? What kind of struggles have they had? And I think there's been such a small number, I can't call it a study. I think there's been case reports.
Yeah, I think that's the issue is we know that reinfection can happen. We always assumed it would be after 90 days. We certainly know that there's been published documented case reports at just over 60 days. I believe the CDC guidance is still that reinfection can happen, but it is not frequent or it is rare. But we always will continue to monitor. Again, the common cough and cold coronaviruses that we've known of can cause reinfection, 6, 9, 12 months down the road too. So there are documented cases of reinfection. It's still not well characterized as far as general population, but we know that the individual case reports are out there. And I suspect that coming up there will be larger cases or cohort studies or more information about reinfection in general, not just these specific published cases.
Okay, I'm going to butcher this.
Go right ahead.
All right.
We'll rescue it.
I don't know these big medical words. Callie said she had read the article regarding the Miami-Dade physician who passed away from thrombocytopenia.
Thrombocytopenia. Yeah, you did good. Well done.
I did good on that one.
Good job.
But it was following the Pfizer vaccine. She has what she calls ITP. Is that the shorthand for it? And she talked with the hematologist who is recommending following the CDC guidelines. She wants to know, what do you guys think? Should she get the vaccine?
All right. Should get the vaccine in the setting of ITP, which is idiopathic thrombocytopenic purpura? Thoughts?
Well, in that particular case,
I'm old.
in that particular case, again, this is a pre-existing circumstance. So these are exactly the patients I want to be vaccinated, those that have underlying disease that are immunosuppressed. And we know that, unfortunately, some of these diseases could be triggered by a virus. We've seen this before with other diseases where viral triggers the underlying disease that person has. And maybe that was a trigger in that particular individual. But at this point, yes, we believe that this kind of patient that has any kind of underlying malignancy or underlying immunologic disorder like that should receive the vaccine.
And just to say, we should have clarified, ITP means you have a very low platelet count. It's kind of an autoimmune process. There's lots of different kinds of therapies for it, but sometimes it can take lives. And Hawkeye, but I don't think we're seeing in those 80,000 plus have been in Pfizer and Moderna studies, or any of the other AstraZeneca, I don't think anybody's been shown, hey, our dose is causing thrombocytopenia or any other kind of autoimmune process.
Yeah, just from that question, it doesn't sound like you have any general contraindications to vaccines in general. This one will be safe. It's recommended that you get it. For any specific questions, though, because your healthcare provider knows the details of your complex medical issues, speak with them. But if they're saying to get it, I would certainly recommend to get it. And for that case, it was certainly tragic, but we don't have all the medical details of that as well. So I think we need to continue. And just to your point, with all the people that have been vaccinated, that hasn't been shown to happen or be common at all.
I think in this age of distrust, one of the things people don't want to listen to sometimes is medical advice, or maybe they might not trust it because they're going to be on the internet and they're going to find all these other voices out there. I think what you have to decide is who you're going to trust. And the problem with a series of one case like that is you just don't know enough of the data. What I would encourage you to do is go look at either the FDA website or either Pfizer or Moderna's website, because I think they've done a really good job of just pushing everything out there, as has AstraZeneca in their trial. When people are willing to just share everything, I think that's a pretty good. You should have a pretty good level of trust around that, and all of us feel confident enough to get the vaccine. And I would urge anyone out there who's got an underlying disease, because that's going to put you at an increased risk for a bad outcome with COVID-19. I would really seriously consider trying to get the vaccine as soon as it's available. Just like every year, you should be getting the flu shot, and you should be making sure you get your MMR and your TDP done. Make sure vaccinations are not evil. They're not going to turn around the world. They don't contain GPS tracking signals that allow us to know what you're going to do, or they're not going to go into mind control. What they are going to do is keep you safe. So the choice you have is to live in a world with COVID-19 where you're not safe, right? Hospitals are overrun. Lots of death. I mean, if you just look at our overall U.S. mortality rate from the COVID-19 crisis, it's really high. Vaccines will help you get safe, and they'll help us get back to normal. But they only work if you get them.
Morgan says, can a person who is 3.5 months out from COVID, still having shortness of breath and cough, get a COVID vaccine? Morgan has read that the vaccine could make long hauler symptoms worse or even trigger immune disease. The look on your face.
Yeah, I'm saying that's just not true. Hawkeye?
Okay.
Yeah, I don't think we have any evidence that it's going to exacerbate the long hauler symptoms. Again, the vaccine is safe. Moderna and Pfizer are really just the spike proteins that's produced, create an immune response to that. It is recommended that if you've had COVID-19 that you should get the vaccine. There's no minimum time between infection and getting that first dose of vaccine or that second dose of vaccine, other than we want to make sure that if you do have the infection, you are staying isolated for those 10 days. So when you can get back out into society, at that point in time, you're able to get the vaccination.
And I think there was either Chinese or Korean data that suggests that after you have COVID-19 now, it looks like that we followed people long enough that you at least have high antibody levels through 8 months, which is great news because it means you're still probably protected. But that, you just don't know the answer to that question yet.
Mm-hmm.
So if I were you, I'd still want to get vaccinated because what you don't want to do when you have long haul syndrome, and you have some lung disease, you have heart problems or the brain fog, you don't want to get sick from COVID-19 again.
Yes.
And that's the real risk to you. And so I think I would get it.
I agree, and I would also stress that we do have a COVID multidisciplinary clinic now available. Get evaluated, and it's going to be helpful because we're going to be able to understand better what's going on in this particular situation, and potentially treat those long-term complications, but also advise you appropriately for the vaccine.
All right, Jill, last question today.
Yeah, last question from Kim. She has a brother who's been sick for 3 weeks with respiratory issues, nausea, and extreme fatigue. 3 times with a COVID swab test, he tested negative. On the 4th test, because it kept persisting, he tested positive. She's asking, how do you explain that?
Hawk?
Yeah, again, I don't know the circumstances. I don't know if those tests were all PCR tests, were they all antigen tests. I think understanding if you have those symptoms, if you know that you've been exposed or not, if you get tested, if it's positive or negative, right now we know that the prevalence in the community is so high. Certainly act as if you had it. Those first 10 days, hopefully he was isolating and continued to be away as much as possible. 3 weeks into it now, if he's continuing to have those symptoms, it's unlikely that it's persistent viral replication, and he may be in that more immune or inflammatory state if this is COVID-19. Certainly I would talk with your physician. If you are having trouble and doing worse and it's progressing and your symptoms are progressing, definitely seek medical care. But if it was COVID-19 and the symptoms have been going on for 3 weeks, it's probably past that acute viral replication stage and more into that inflammatory stage. And I guess we should also say, that we understand that there can be false negatives on some of these tests and false positives as well. So that is not
and it's still a user error. If it's not done right,
correct.
it's not done right, you're not going to have the right result. I had one of my own patients had that happened just recently, and they had a couple of negative tests. I'm like, I think you had it. His wife had it, his daughter had it, and her son had it, and so it's like, yeah, let's just do the antibodies. His antibody test.
Yeah, one indirect way of looking at that, especially if you're at 3 weeks out, is going to get an antibody test, and that will just tell if you've had exposure to the virus.
Final thoughts today or quiet about this question?
Yeah, no, I do want to mention that this Active 2 study, we're going to roll out in the next week or two some new treatments. I just want to touch base on those because when we roll out those new treatments, they're going to be available to everybody 18 and above, not just high risk. So you can think about it if somebody's not high risk, you may want to use an oral agent. So we're going to be testing an oral agent called Camostat. We're going to be testing an intramuscular injection of a combination of monoclonal antibodies. And we're going to be testing an inhaled agent, a nebulized interferon beta, which may augment our response to viruses or protect us in terms of, or treat us, help us in the treatment of respiratory viral infection. Those 3 new agents should be available within our Active 2 trial within the next couple weeks.
That is so exciting. You got to come back and talk to us about that.
Yes, we will.
Bring some more cool pictures because it's really, it is really important. Yeah. We want to help get people into those trials. And there's also, I've read reports about potential oral therapy that would be like Tamiflu, but for COVID-19. Yep. We got anything like that on the horizon?
Yeah, this agent, it's actually reuse of something that's been around for many years, so it's going to be very interesting, but it potentially would augment how you fight off an infection and perhaps prevent these long-term complications that we're seeing.
All right. Well, thank you for being here, and thanks for all you
Thank you,
do. We
Steve.
love the fact that you're here at KU. Hawk,
Yeah,
final
you know, I
thoughts
think
today?
the interferon, if you're able to get that study going, I think sounds exciting. We really believe that some of the initial phases of the viral infection is able to decrease our interferon or one of our antiviral responses. So I think maybe giving that at the right timing could certainly help to augment some of that disease. Good vaccine questions. I was thankful that Dr. Norman was able to be on our show and describing the new stages for vaccine to really get that vaccination out, distributed, and into the arms of the general population as soon as possible.
All right. Thank you all very much. What a great program today. Hey, tomorrow, pulmonologist Dr. Leslie Spikes joins to talk more about chronic lung injury from COVID-19 patients, the types of lung injuries and then chronic injuries in general that they're weathering, and how the COVID-19 clinic will help address, track, and study the long-haul effects of this disease. We're also going to be checking in with Anil Gallmarker, who has been on this program before. Anil, thanks for getting ready to come back. We're going to see how his lung issues are progressing since he contracted COVID-19 in April. On Friday, for those of you who are interested in learning more about the viral variants and how the current vaccines stack up, Dr. Greg Poland, the director of the Mayo Clinic's Vaccine Research Group, is going to be back on our program. He was here with us before. He's a great guy. I think you'll really learn a lot. I'm anxious to hear from him because I love to listen to him. He's just a good guy. He's very thoughtful, and I think he's one of those truth tellers out there. Hey, you know, in this time out there of the great contentiousness where we seem to fight over everything from the sky, the color of the sky, to whether or not masks keep you safe, I would urge you to sit back and listen to the science. We said before, faith helps keep us strong. Hope gets us through to tomorrow. Science gets us back to the way we want to be. Together we can do that, but we have to tell the truth, we have to be honest, and we have to take care of each other. If we do that, we can beat COVID. Those rules of infection control that we talk about all the time, keeping your distance, wearing a mask, don't go out in public. If you're sick, cough into your elbow, wash your hands. Those rules of infection control, they travel with you wherever you go, and they keep you safe. And that is the truth. We're here tomorrow, and remember, there's still no place like home. We'll see you soon.